So today we're going to be talking about echocardiography in systemic disease. I have no disclosures. In terms of our objectives today, we're going to identify systemic illnesses with cardiac involvement. We're going to identify the echocardiographic findings in these disorders, and we're also going to touch on the available medical treatment options. So many systemic diseases can have direct involvement to the heart and can result in cardiac dysfunction. And echocardiography can help us identify unique characteristic features, which can be the first clue to the underlying systemic illness. In addition, recent advances in the multimodality imaging have impacted the management of these conditions, since they also provide valuable information while avoiding the use of invasive techniques. So we're going to be talking about a few cases today. Our first case is a 60-year-old man with worsening dyspnea on exertion for the past 3 months. In terms of his past medical history, he's been complaining of worsening neuropathic pain to his lower extremities, and he's also been experiencing symptomatic orthostatic hypotension. His ECG shows low voltages in the limb leads, as well as poor wave progression across the precordial leads, and he previously underwent a coronary angiogram, which was non-remarkable. This here shows the parasternal long axis views, and we can appreciate that this patient has concentric left ventricular hypertrophy. The myocardium has a speckled appearance to it, and the LV function in this case was normal. On the apical four-chamber view, we can appreciate that this patient has severe biatrial enlargement. The intraatrial septum does appear thick. And looking at the subcostal view, we can appreciate that he does have a small pericardial effusion, and there's also a mild hypertrophy to the right ventricle. In terms of diastology, in this case here on the left, we can see the pulsed wave Doppler of the mitral inflow. In his case, the E/A ratio is greater than 2, and he was noted to have a short deceleration time. So in this case, this was in keeping with a restrictive filling pattern. And looking at the TDI of the mitral annulus, we notice that the septal and lateral velocities are also very low, which reflect abnormal myocardial relaxation and compliance. Looking at the global longitudinal strain pattern in this case, we notice that he does have the apical segmental strain values are greater than those in the basal and middle segments, and this gives us the characteristic apical sparing pattern. So just to summarize, we have a patient here with exertional dyspnea with clinical evidence of heart failure. And I just wanted to highlight this algorithm that was published in JACC in 2018. His echo shows a preserved LVEF with increased LV wall thickness. So the differential in this case includes hypertensive heart disease, HCM, and infiltrative cardiomyopathies. He was not hypertensive on exam, and if anything, he was experiencing episodes of orthostatic hypotension. And given that we did have evidence of restriction in this case with severe impairment in his diastolic function, our differential would mostly include infiltrative restrictive cardiomyopathies such as amyloid and glycogen storage disease. Given that the clinical suspicion for amyloid was high in this case, our patient underwent additional investigations. His lab work, including serum and urine protein electrophoresis, as well as free light chain assays, were non-remarkable. He eventually had a pyrophosphate scan, which was strongly positive with grade 3 uptake, and this led to the diagnosis of transthyretin cardiac amyloidosis. So cardiac amyloid is a form of infiltrative cardiomyopathy due to the deposition of amyloid fibrils within the myocardium. The two main precursor proteins leading to cardiac involvement are immunoglobulin light chains, which lead to AL amyloid, and we can also have the liver-derived transport protein transthyretin, which is responsible for the development of transthyretin amyloidosis. We're going to focus on TTR amyloid as we see it in general more frequently compared to AL amyloid. TTR stands for transthyretin, which is the transporter of thyroid hormone and retinol binding protein. It's made in the liver, and it's also known as prealbumin. So this is a common protein that we all have, and it's usually tightly folded in a stable tetramer. But in some cases, this tetramer dissociates either due to aging or because of a genetic mutation, and that's when it becomes misfolded, and you eventually end up with the deposition of amyloid fibrils within the myocardium and the peripheral nervous system. The echocardiographic findings in patients with TTR amyloid can often resemble those of many other illnesses, such as HCM. So, in patients with TTR amyloid, we generally see a moderate increase in the LV wall thickness, while in HCM, we can see a more variable range of LVH. Usually in TTR, we can see concentric hypertrophy, where in HCM, again, we can see some variations in the pattern of LVH, and this includes asymmetric hypertrophy patterns as well as apical hypertrophy. In amyloid, we more frequently see an increase in the thickness of the RV free wall and the interatrial septum, not so much with HCM. Pericardial effusions are also more frequently seen in amyloid. We can also see restrictive filling patterns in advanced cases of amyloid-associated cardiomyopathy. And finally, the longitudinal left ventricular function is more severely reduced in TTR compared to HCM. This here is a case highlighting the autopsy results of a patient with cardiac amyloid. The investigators looked at the load of amyloid at 3 sections of the LV, and essentially they found that there was increased deposition of amyloid fibrils within the basal and mid-cavitary segments of the LV compared to the apex. And this, in theory, could explain the apical sparing patterns that we see on longitudinal strain. As we mentioned before, patients with cardiac amyloid can have a restrictive filling pattern on their echo. Deceleration time is the time interval from the peak of the E wave to its projected baseline, and a shorter deceleration time is a marker of diastolic dysfunction. This study here looked at the survival of amyloid patients based on their diastolic function profiles. And what they found was that patients with shorter deceleration times, as well as patients with increased early diastolic filling velocities, had the worst survival. So essentially, the degree of diastolic dysfunction reflects the extent of amyloid infiltration within the myocardium, and this could be helpful in determining the prognosis among these patients. We have the Canadian guidelines on the evaluation and management of patients with cardiac amyloid, which were published in 2020. They outline key clinical features to look for when you're suspecting cardiac amyloid. So this includes unexplained increased LV wall thickness, low flow, low gradient aortic stenosis with a preserved LVEF, bilateral carpal tunnel syndromes, as well as peripheral neuropathies. And finally, you should suspect amyloid if you do have established amyloid in a non-cardiac organ, such as AL amyloid causing nephrotic syndromes, for instance. The guidelines also outline a diagnostic algorithm for the evaluation of suspected cardiac amyloid. The first step of the algorithm is to screen for plasma cell dyscrasias by doing serum and urine protein electrophoresis with immunofixation, as well as serum free light chain assays. In the case of absent monoclonal proteins, then we suspect transthyretin amyloid. The recommendation is to proceed with a pyrophosphate scan, which has a high level of diagnostic accuracy for confirming TTR cardiac amyloid. A positive result on the pyrophosphate scan is defined as grade 2 uptake or higher. And once we confirm the diagnosis of transthyretin amyloid, it's recommended to perform genetic sequencing to help distinguish wild type from hereditary amyloid. As per the Canadian guidelines, the management of cardiac amyloid can be divided into 2 parallel pathways. The first pathway focuses on the management of cardiac signs and symptoms, and this includes diuresis in cases of volume overload, anticoagulation in atrial fibrillation, and pacemaker implantation among patients with symptomatic bradycardia. The second pathway focuses on the prevention of further amyloid deposition within the heart through the use of disease-modifying agents. So this includes chemotherapy or stem cell transplantation in patients with AL amyloid, tafamidis for transthyretin amyloid cardiomyopathy, patisiran for amyloid patients with symptoms of polyneuropathy, and finally, liver transplantation in advanced transthyretin amyloid cases. The tolerance to the classic heart failure medications among patients with cardiac amyloid is poor. These patients are dependent on their heart rate to increase their cardiac output, so they may not necessarily tolerate beta blockers. Also, a high proportion of these patients have autonomic dysfunction with symptomatic orthostatic hypotension. So advancing GDMT among these patients, especially among those who develop LV dysfunction, can be a clinical challenge. So this here was a retrospective study that looked at the outcomes among amyloid patients with LV dysfunction, and it also looked at the discontinuation rates of goal-directed medical therapy due to intolerance or because of side effects. And what they found was that there was a survival benefit of beta blockers, but the tolerance was very poor. And in contrast to beta blockers, MRAs were better tolerated and were also associated with a reduced risk of mortality in this patient population. I just wanted to highlight the major RCTs that looked at the different interventions to slow down the progression of amyloid. The ATTR ACT trial showed that tafamidis, which stabilizes transthyretin tetramers, is superior to placebo in reducing the combination of all-cause mortality and cardiovascular-related hospitalizations. More recently, the Helios-B trial was an RCT that was just presented at the ESC Congress this year in London. And essentially, it was shown that vutrisiran, which is an RNA silencer, led to a lower risk of death from any cause, as well as a reduction in cardiovascular events among patients with transthyretin amyloid-related cardiomyopathy. So this leads to our second case. This is a 33-year-old man who is referred for an evaluation of dyspnea. He is known to have beta thalassemia major and has been transfusion dependent. He's complaining of NYHA class 3 symptoms, and he was found to be mildly volume overloaded on exam. And apart from that, he was also noted to have bronze skin as well as scleral icterus. This patient underwent an echo, which shows severely dilated LV with severely reduced LV function. And when we look at the GLS pattern, we note that there is diffuse decrease of strain. So we have a young patient here with dilated cardiomyopathy. By definition, as per the ESC guidelines for the management of cardiomyopathies, DCM is defined as the presence of LV dilatation and global or regional systolic dysfunction unexplained by abnormal loading conditions or coronary artery disease. There are several non-genetic causes to DCM, and this includes viral causes such as in post-myocarditis cases. Certain drugs are also directly cardiotoxic, such as alcohol and cocaine. Iron accumulation within the heart is also cardiotoxic. Certain endocrinopathies have also been associated with DCM, such as hypo and hyperthyroidism. So in terms of relevant lab work, his ferritin, TSAT, and iron levels were all very high. So this patient goes for a cardiac MRI. The cine images of the MRI were also consistent with global LV dilatation and dysfunction. There was no evidence of late gadolinium enhancement, but the T2 star relaxation time on his MRI was very short at 8 milliseconds, which was very suggestive of iron overload within the myocardium. So hemochromatosis can either be caused by excessive iron absorption in the small intestines, typically due to an HFE gene mutation, or it could be caused by exogenous iron administration, and it can be seen in patients who need recurrent blood transfusions. Iron studies are the initial test used to determine whether there is clinical evidence of iron overload, and hemochromatosis may be a cause of dilated cardiomyopathy, which is usually reversible with treatment. And the treatment is usually through phlebotomy or iron chelation therapy. Cardiac MRI is very important in establishing diagnosis and monitoring treatment effects. The evaluation of the T2 star relaxation time is an excellent non-invasive correlate of myocardial iron deposition, and it's also useful to follow to determine the response to iron chelation therapy. The T2 star relaxation time was also shown to predict the risk of developing heart failure and arrhythmias among that patient population. So this is our third case here. This is a 50-year-old man who presents for an evaluation of intermittent palpitations. He had an episode of syncope in the past and was noted to have intermittent episodes of NSVT on his Holter monitor. His coronary angiogram was non-remarkable. His chest X-ray was consistent with hilar lymphadenopathy, and he was noted to have tender red lesions on his shins concerning for erythema nodosum. This echo is done here at St. Mike's. So on the parasternal long axis views, the LV is severely dilated with moderately reduced LV function. And we can also appreciate thinning of the basal interventricular septum. On the apical fourth chamber view, both the LV and the RV appear to be very trabeculated. The RV is also moderately dilated with moderately reduced systolic function. There's severe biatrial enlargement, and again, we appreciate thinning of the basal interventricular septum. This patient went for a cardiac MRI. On the cine image, again, we do appreciate the basal septal thinning, but this patient was also found to have diffuse and patchy subepicardial late gadolinium enhancement, which was very suggestive of cardiac sarcoid. So sarcoidosis is a systemic inflammatory disease. The hallmark on histology is the presence of non-caseating granulomas. Because of the patchy nature of the infiltration, cardiac biopsy has a low sensitivity, and we rely heavily on imaging to make the diagnosis. Patients with cardiac sarcoid can have variable presentations, which ranges from heart block to ventricular arrhythmias and heart failure. So it remains a diagnosis of exclusion, and coronary artery disease should always be considered when assessing these patients. In terms of screening for cardiac sarcoid, you should always screen when you have a patient with a biopsy-proven extracardiac sarcoid with some clinical suspicion for cardiac involvement. So this includes frequent palpitations, history pre-syncope, or if the patient has an abnormal ECG or an echo. And among patients with no history of sarcoid, you should think of possible cardiac sarcoid if you have a young patient with unexplained advanced AV block, or in the case of sustained monomorphic VT with no clear etiology. Typically, you start screening with a cardiac MRI. If the cardiac MRI is negative and there is a high clinical suspicion, you proceed with PET. And if the MRI is positive, it's also reasonable to proceed with a PET scan to see if there is any active inflammation. So based on your investigations, you can have these different results. If the cardiac MRI is negative and the PET is negative, there's no cardiac involvement. If the cardiac MRI is positive but the PET is negative, that's burned out cardiac sarcoid, and you wouldn't treat these patients with immune suppression. And finally, when the PET is positive, that's when you want to treat these patients with immunosuppressive therapy. On echo, initially we see unifocal involvement of sarcoid, which manifests as regional thinning and hypokinesis of the basal interventricular septum. As the disease progresses, you can start to see regional wall motion abnormalities or focal aneurysms that are not in a coronary distribution. And finally, with diffuse infiltration of the myocardium, we start to see LV dilatation and systolic dysfunction. So that was the end of this case. Our next case is a 76-year-old lady who presented with focal neurological symptoms. She had a brain MRI which showed multiple ischemic lesions suggestive of cardiac embolism. She was also noted to have an elevated white cell count and ESR. An echo revealed a large mass covering the apical 2/3 of the LV. The LVEF was estimated at 58% with reduced LV volumes, and we also note that her left atrium was severely enlarged. When we look at the mitral inflow pattern, we note that the ETA ratio of more than 2 with a short deceleration time. Again, this is consistent with grade 3 diastolic dysfunction with a restrictive filling pattern. And looking at the TDI of the mitral annulus, we also note that the septal and lateral velocities are very low, which reflect abnormal myocardial relaxation. So the differential that comes to our mind when we look at this this case includes apical HCM, ischemic heart disease with apical thrombus, hypereosinophilic syndrome, as well as LV non-compaction. She underwent a cardiac MRI, which again showed a large apical thrombus, and there was also an evidence of significant subendocardial late gadolinium enhancement, and this was highly consistent with endomyocardial fibrosis. So in EMF, we have increasing levels of circulating eosinophils. This could be mediated by an autoimmune disease, malignancies, or it could be mediated by parasitic infections. In the acute phase, the eosinophils infiltrate the myocardium and cause direct tissue damage, and this causes platelet aggregation and thrombus formation. And eventually, this leads to scarring and fibrosis, which can result in a restrictive physiology. Just to summarize the major echo findings in EMF, we can see endomyocardial thickening involving the LV or the RV. There can be mural thrombi in the apex, and the apex is usually normal or hyperkinetic. There will be a small ventricular cavity due to the endocardial thickening and the mural thrombi, and there can also be a restrictive flow pattern seen across the mitral valve. So this is our final case here. This is a 39-year-old man with diarrhea, flushing, and weight loss. He was diagnosed with carcinoid syndrome. On his echo, you can appreciate how the tricuspid leaflets are fixed and retracted with wide open tricuspid regurgitation. Pulsed wave Doppler of hepatic veins also show substantial systolic reversal of flow, which is also a sign of severe tricuspid regurgitation. Similar to the tricuspid valves, the pulmonary valve leaflets are thickened and retracted, and they also do have restricted mobility. And this we can also appreciate severe pulmonic regurgitation in this case. In patients with carcinoid heart disease, the tumor is usually in the small intestines and it metastasizes to the liver. This causes the release of vasoactive peptides, mostly serotonin, into the IVC, and it causes damage to the right-sided heart valves. And what we see is endocardial thickening with retraction and fixation of these valves, causing severe valve regurgitation. We do have limited medical options available for treatment of carcinoid heart disease. The treatment of choice in these patients with severe symptomatic tricuspid or pulmonic valve regurgitation is surgical. This here was a study that was done at the Mayo Clinic, and they looked at surgical outcomes of patients with carcinoid heart disease. And essentially, most of these patients had tricuspid valve replacement. And this shows an improved survival among carcinoid patients who underwent valve replacement. And the greatest survival benefit was seen among patients who underwent surgery at an earlier stage of their disease. So that was my last case. So just to summarize my talk, that was a quick overview of the echo features in systemic disease. Echo can help us identify characteristic features, which may be the first clue to the underlying systemic illness. And we also highlighted the value of multimodality imaging to improve diagnostic precision and response to treatment in these cases. Thank you so much for listening. I'm happy to take any questions.